Okay, I better speed up here, just because of time. So chronic obstructive pulmonary disease. So this is a chronic condition that has two parts to it, right? So emphysema, which is alveolar uh, destruction, so lung destruction, and chronic bronchitis. So emphysema and chronic bronchitis. Okay, chronic bronchitis is excessive mucus production and chronically damaged bronchial tubes. By far the most common cause, smoking. Um, in a distant second would be air pollution. Okay, and it's irreversible. It's a chronic condition. Okay, there's actually a genetically inherited version of it called alpha 1 antitrypsin deficiency, where patients develop COPD. Okay, because in that condition, you lose the elasticity and recoil of the lung. Okay, and what happens is because of the emphysema, you're going to lose surface area of the lung, and you're going to have difficulty exchanging gases, um, such as oxygen and CO2. Oxygen and CO2. And on top of that, you have the chronic bronchitis and excessive mucus production. So you're going to have wheezing, shortness of breath. Okay, and we'll talk about those. So really, the key in terms of prevention is getting people to quit smoking and avoiding secondhand smoke. Okay, wearing proper equipment in potentially dangerous environments where there's particles that can get into the lungs and damage them. So workplace environment is really important. Um, Patients with COPD should definitely have an annual influenza vaccine and also have a pneumonia shot, a pneumovax, to prevent significant flare-ups of their COPD because they're at risk of getting recurrent infections, right? So what are the main risk factors for this disease? Well, the older we get, the more lung damage we can incur. And the biggest risk factor, smoking. Alpha 1 antitrypsin deficiency, I mentioned, is a genetic condition um, that can lead to COPD. Okay, so you don't need to be a smoker necessarily to have COPD. And exposure to rising levels of air pollution can damage the lungs because of all the particulate matter and lead to COPD as well. So here's the two components of COPD. Emphysema, okay, that's the alveolar destruction. And when you destroy the alveoli, you lose lung elasticity, meaning the lungs are becoming floppy. So you can inhale really easily, um, but there's going to be chronic bronchitis with this, so it's going to be difficult to exhale completely. And we'll talk about that. So hyperinflation of the lungs is due to the fact that the lungs can't recoil anymore. They've lost their recoil ability because the lung tissue is being destroyed. So they typically breathe at very high lung volumes because they don't completely exhale. And that's why they're going to have a barrel chest. Okay, the other component, chronic bronchitis, which is inflammation of the bronchial tubes, causing the wheezing, the chronic mucus production, the chronic coughing up of phlegm. So what are the expected findings of someone with COPD? Well, definitely dyspnea on exertion. And if it gets really bad, it'll be dyspnea at rest. So just sitting there, some people are short of breath all the time. Um, and it just depends on the severity of the COPD, right? And just keep in mind what's happening. The chronic bronchitis with the wheezing and chronic cough, and the alveolar destruction with the low O2 sats and the difficulty clearing CO2 out of their body. Productive cough is always there with COPD. They have a productive chronic cough with phlegm production. Okay. Hypoxemia, so low O2 sats, because they're losing their diffusion ability at the alveolar level, because they're losing alveoli. Crackles and wheezes in their chest, well, the wheezing is from chronic bronchitis. The crackles and crepitations in their lungs that we hear are from the lung damage and scarring. Tachypnea, they're having to breathe faster to maintain oxygenation and trying to clear the CO2 out of their blood. Shallow respirations is really because they're breathing at higher volumes all the time. They're not completely exhaling, so they're always breathing at the higher volumes. So they take smaller breaths because they're always breathing at those higher volumes, right? Barrel chest is for the same reason, because they're not completely exhaling. They always have a larger appearing chest because they always have higher lung volumes in them. Thin extremities, why? Because they're chronically using more energy to breathe. So they're often thin. Okay, they don't have to be, but they're often thin because of that. Sometimes they have to use their accessories, their accessory muscles of respiration. So they may have enlarged neck muscles. Dependent edema, so edema in their legs. Why? Well, they can start to develop cor pulmonale, or right-sided heart failure, because the blood vessels are being destroyed in the lungs as well, and that's causing pulmonary hypertension in the pulmonary artery, and that's going to cause the right ventricle to fail, which causes peripheral edema. Clubbing of their fingers and toes can happen because this is a chronic hypoxemic condition, and that's what gives you clubbing. Okay, so whether it's a chronic cardiac condition or chronic lung condition such as COPD or cystic fibrosis, you can develop clubbing. Cyanosis, sure, that's deoxygenated blood. So if they have poor O2 sats, they can be cyanotic. So blue lips, blue fingernails, okay? And of course, decreased O2 saturations on a pulse oximeter can definitely happen. Many patients with COPD actually have, at a normal baseline, a low O2 sat of, say, 88%, 89%. Okay, they just live at that level. They're never in the normal range. Okay, so let's look at some diagnostics for COPD. I mean, not all of these tests directly lead you to a diagnosis of COPD. They just can help when they're all kind of put together, a diagnosis of COPD. So increased hematocrit. Well, if you're chronically low on oxygen in your bloodstream, that's going to trigger your bone marrow to make more hemoglobin, right? It's going to trigger production of erythropoietin from your kidneys. That will go to the bone marrow and say, make more hemoglobin. So because of the low oxygen, they can have an elevated hematocrit. In fact, smokers often have an elevated hematocrit because they have chronically low oxygen because it's being replaced by carbon monoxide. Someone with COPD, if they have a flare-up, sure, we could get sputum cultures. We could do a CBC, looking at their white blood cell count to see if it's elevated. Okay, so sputum cultures to see if they're bearing an infection. White blood cell count to help us to see if there's a infectious process occurring, because COPDers are at risk of getting recurrent pneumonias. Arterial blood gases can be used to determine the level of hypoxemia. So we're going to get a PaO2 and we'll get an O2 sat on an arterial blood gas. And also, what's their CO2 level? Are they still able to clear their CO2 from their bloodstream and have a CO2 level between 35 and 45? Or do they retain CO2 because their emphysema or COPD is so bad that they're not able to clear their CO2 out of their bloodstream? Okay. What tests can we get breathing tests, so pulmonary function tests can be obtained. How are they going to help? Well, usually these patients have difficulty getting air out, like in asthma, because they have all that mucus and bronchial damage. So they have difficulty forcing the air out fast. So their what's called forced expiratory volume is diminished. They can't get the air out fast. And in particular, what's called the forced expiratory volume in 1 second is low. So they can't get much air out very quickly. And as it gets worse and worse and worse, their forced expiratory volume that they can do in 1 second is vastly diminished because they just can't get the air out very fast. Okay? So if given a long, long time, they can get the air out, but how much they can get out in 1 second is vastly diminished. Okay, so pulmonary function tests are really used to help us see lung volumes and how much air someone can get out when they exhale. Okay, chest X-ray, yeah, that's going to help. It's going to show hyperinflated lungs because they're not getting the air out, so they're breathing at high lung volumes. Flattening of the diaphragm will occur as well. And if we really don't know the cause of someone's COPD, we can do a blood test looking for alpha-1 antitrypsin. Okay, and this would only be in someone who has COPD. They're not a smoker, they haven't been exposed to pollutants, and we think maybe this is inherited. Okay, so there's pulse oximeter, which is an O2 saturation monitor. And I mentioned that often patients with COPD live at relatively low O2 saturation, say of 90% or 88%, and that's just their baseline. Okay, and that will matter because when they come back with a COPD flare-up, we always like to know what's their baseline oxygen saturation. Because if it's about the same, well, that's good. They're able to maintain the same oxygenation in their blood. But if it's vastly diminished, we know that that compared to their baseline, they're performing poorly and they're not oxygenating their blood very well. Sorry about that. Okay, so what can we do with someone who comes in with a COPD flare-up? Well, positioning, so upright. Sometimes if they're having a significant flare-up, they're leaning forward and they're tripoding. They're holding the table in front of them to try and stabilize their chest wall. Sitting in high Fowler's position is a good idea. So upright in the bed to get as much oxygen flowing in and out of the lungs. These people would not lie down flat for sure. In terms of the airway, suctioning to see if you can help them with thick secretions. The ICOF acronym that we already spoke about. Assessment, well, they typically have increased respiratory rate because of all the mucus and bronchoconstriction, and they're hypoxemic, so the brain is making them breathe faster. They often have a prolonged expiratory phase, right? They're wheezing, so they can't get that air out very well. Okay. In terms of monitoring, so skin breakdown, especially if they're receiving a lot of high flow oxygen, so whether it's around their nostrils or drying out their mouth and causing ulcers or skin breakdown around their mouth, that's important. Administration of medications we'll talk about. A lot of them are very similar to asthma. Chest physiotherapy, where we can percuss different parts of the lungs to try and release some of the secretions and mucus that's making them short of breath. Remember that with oxygenation, we don't want to over-oxygenate them. So If someone usually lives at 88% on an O2 saturation, we don't want to get them to 99% because at 88%, that's telling the brain, keep on breathing at this rate for this person. And if you get them up to 99% with oxygen, the brain's going to say, you don't need to breathe as fast. You don't need to breathe as deeply. And they're going to slow down their breathing, and they're going to retain carbon dioxide, which is going to make them lethargic, tired, and potentially need intubating. Okay, so we're careful with COPDers not to give them too much oxygen. Okay, we just want to get them to their baseline. We don't want to get them to a normal O2 sat of 95% or greater. Okay. Adequate nutrition is important because they use a lot of energy because of the increased work of breathing. Okay. Now, what else can we do with someone who comes in with COPD? Let's talk about some medications. So they're very similar to asthma. The short-acting beta agonists to bronchodilate, ipratropium, which is the anticholinergic, to also bronchodilate. Sometimes theophylline, which is a methylxanthine, to try and also bronchodilate, right? It's a bronchodilator, similar to caffeine. Okay. We can use corticosteroids, whether it's in an inhaled form or an oral form such as prednisone, or in an IV form. We can use those. We use them all the time to try and settle down the inflammation in the lungs. We definitely put patients on antibiotics for a COPD flare. So if someone comes in more short of breath, more mucus, more purulent phlegm, we can use all of these inhalers and bronchodilators and corticosteroids, plus we put them on an antibiotic because often they've developed a bacterial infection. Okay, so these COPD medications we've spoken about, so it really depends on whether we're talking about someone who's just being maintained and treated for their COPD versus someone who comes in with a COPD flare-up. Okay, so in terms of bronchodilators, albuterol and ipratropium can certainly be used regularly to keep their airways a bit open. Anti-inflammatory agents, usually we'll try and give them inhaled anti-inflammatories such as fluticasone, but during a flare-up, we will give them oral prednisone. Okay. The bottom ones, the montelukast, which is that leukotriene inhibitor, cromolyn, which is a mast cell stabilizer, they're not overly effective for this condition. Definitely the corticosteroids are the mainstay in terms of anti-inflammatory agents. Mucolytics, if we think they just can't cough up all this thick phlegm that's stuck down there, and we can give them acetylcysteine as a nebulizer. Don't forget, with a COPD flare-up, we give antibiotics because a lot of these patients have an underlying bacterial infection that's caused the flare-up to begin with. So in terms of patient education, COPD is typically a progressive disease. So a progressive decline in lung function from chronic bronchitis and emphysema. And there's a percentage of people that are going to develop right heart failure, right? Because of that pulmonary artery hypertension. And when they develop right heart failure, they're going to have peripheral edema. They're going to have an enlarged heart. They're going to have an enlarged liver because there's backup of blood because it can't leave the right ventricle very well to get to the lungs due to the hypertension in the lungs. When you have backup of blood, don't forget you'll have an enlarged liver, but what drains to the liver? Well, all the nutrients from the small intestine, right? So, and all the blood is going to be engorged in the veins around the small intestine. So often these patients say, I can't eat very well, I fill up really quickly, I'm nauseated when I eat, because the blood's not flowing very well from the small intestine to the liver. Okay? And of course, they have swollen feet with right heart failure. Some patients need to go home on home oxygen, so they're going to need education about not smoking. Well, actually, they should stop smoking because continuation of smoking results in a faster decline in COPD. But on top of that, home oxygen, you really can't smoke and be on oxygen therapy at the same time, just because it's combustible. Okay. High caloric intake, important because of all the energy they're using to maintain ventilation. Okay. Discussing rest periods throughout the day because they're working so hard to breathe, right? And remember, some people are short of breath even at rest. Adhering to the medications is really important. Their bronchodilators and their anti-inflammatories, and also being educated about when to come back if they have a COPD flare-up. They're more short of breath. They're coughing more. They're producing more phlegm. That's typically a COPD flare-up. Okay. Making sure that they take the annual flu vaccine and they get a pneumonia shot. That's important. Some people go to pulmonary rehabilitation clinics where they have exercises that they receive regularly for pulmonary rehab. Okay, and maintaining a good fluid intake, assuming you don't have heart failure. Okay, if you have heart failure, then we typically don't recommend large volumes of fluid. Okay, so let's do the questions at the end of the chapter of COPD. Just before then, I'm just going to mention two complications of COPD. So the first one is recurrent lung infections and COPD flare-ups, right? So patients come in with a history of COPD, but now they've come in more short of breath, more sputum production, and discolored sputum, okay? So typically they need higher levels of oxygen if they're on home oxygen, or they just need oxygen therapy if they're not on oxygen at home. We monitor their oxygen levels. We often will do blood work looking for an elevated white blood cell count, and they also need antibiotics on top of bronchodilators and glucocorticoids. Okay, so we want to open up the airway. We want to treat the infection with antibiotics, and we want to decrease the inflammation with glucocorticoids such as prednisone. Other complication is right-sided heart failure. So with COPD and alveolar destruction from emphysema, you also get destruction of tiny capillaries. And that leads to difficulty for the blood to flow through the lungs because the capillaries are being destroyed. And that causes pulmonary hypertension. So pulmonary artery hypertension. And the poor right ventricle now has to pump against higher pressures to get blood into the pulmonary artery. And that's going to lead to right ventricular failure because it's working harder all the time. Okay? And it's called cor pulmonale. So they're going to get symptoms and signs of right-sided heart failure. So what are the symptoms and signs? We mentioned them already. So a low O2 saturation because they're not getting blood from the right side of the heart to the left side of the heart very well. So when we put an O2 sat monitor on, we see that the blood is poorly oxygenated, okay, because of the fact that it's just not pumping very well from the right ventricle. And that's going to cause cyanosis, right? Bluish lips, bluish tinged nail beds. Enlarged liver, I mentioned, and with an enlarged liver, you have problems getting the blood back from the small intestine because the liver is blocked or engorged with blood, and that's why they have anorexia, loss of appetite, a fullness after they eat. Distended neck veins, again, just has to do with inability of getting blood back to the right side of the heart. And of course, peripheral edema. Same reason. Okay. So we give them oxygen therapy. We monitor their gastrointestinal symptoms, all because of that hepatomegaly and poor blood flow return from the small intestine. A lot of these patients have to go home on home oxygen, right? They're often hypoxemic. Okay, so let's do the questions. At the end of the chapter. So number 1, a nurse is providing discharge instructions to a client with COPD and a new prescription for albuterol. Which of the following statements by the client indicates an understanding of the teaching? This sugar can increase my blood sugar. This medication can increase my blood sugar levels. No, that's glucocorticoids, such as prednisone. This medication can decrease my immune system. No, that's glucocorticoids as well, such as prednisone or methylprednisolone. I can take an increase in my heart rate while I can have an increase in my heart rate while taking this medication. Yes, it's a beta-2 agonist. It's going to cause tachycardia. I can have mouth sores while taking this medication. No, that's more commonly the glucocorticoids because they can cause thrush and oral ulcers. Okay, so the answer is C. Number 2, nurse is preparing to administer initial dose of prednisone to a client who has COPD. So prednisone is oral. The nurse should monitor for which of the following adverse effects. So hypokalemia. Okay, so let's just get this straight. So corticosteroids have a steroid ring. Okay, that makes sense. They're steroids. They have a steroid ring. Aldosterone, which is a hormone in your body, has a steroid ring. So what does aldosterone do? It reabsorbs sodium and gets rid of potassium. And by the way, it also reabsorbs water. Okay, so what's cortisone going to do since it's similar in shape to aldosterone? Reabsorb sodium, reabsorb fluid, and decrease and get rid of potassium. And that's why you're going to have fluid retention with corticosteroids, and you're going to have hypokalemia with corticosteroids. So A is correct. B is with beta-2 agonists, so not with corticosteroids. C is correct, fluid retention, right? You're reabsorbing salt or sodium and fluids. D, nausea. Well, that's not a fair one. Corticosteroids upset the stomach and can cause nausea, so I think that one should be correct. I think they're trying to get at the fact that beta-2 agonists also cause that. I don't agree with that not being included. Black tarry stools from peptic ulcers and bleeding ulcers from the corticosteroids. So A, C, and E. I think D is correct as well, if you chose that. A nurse is discharging a client who has COPD. The client is concerned about not being able to leave the house due to the need for staying on continuous oxygen. Which of the following responses should the nurse make? There are portable oxygen delivery systems that you can take with you. Absolutely. Lots of portable oxygen systems so you can go out. So that's going to be the answer. When you go out, you can remove the oxygen. No, that's not a good idea. You're going to become hypoxemic. C, you will probably not be able to go out as much as possible. That's not true with the portable devices. D, home health services will come to you so you will not need to go out. No, that's not accurate. You can still go out. So A is the answer. 4, a nurse is instructing a client on the use of incentive spirometer. Which of the following statements by the client indicates an understanding of the teaching? So an incentive spirometer is to encourage you to take deep breaths to avoid atelectasis or to avoid a post-op pneumonia, right? It keeps the alveoli opening, especially if you do it every hour. So A, I will place the adapter on my finger. No, that's an O2 sat monitor. That's not an incentive spirometer. I will lie on my back with my knees bent. No, that's not, no, you wouldn't use an incentive spirometer lying on your back with your knees bent. I will rest my hand over my abdomen to create resistance. No, that's not part of the use of an incentive spirometer. That would be an abdominal breathing exercise. I will take in a deep breath and hold it before exhaling. Yeah, you're trying to keep that ball that's in the incentive spirometer at the top. It's, it's, it's encouraging you to take a deep breath, right? So D is the answer. 5, last one. The nurse is planning to instruct the client on how to perform pursed lip breathing. Which of the following statements should the nurse include? Take quick breaths upon inhalation. No, pursed lip breathing is about exhaling here. Place your hand over your stomach. Okay. Take a deep breath in through your nose. Okay, so that would be part of pursed lip breathing. Okay, to control your breathing and bring it in through your nose, and then when you exhale, you're doing a different technique. I don't really agree with this answer either. So pursed lip breathing is where, sure, you're slowing down your breathing so you can breathe through your nose, and then after you've inhaled, you pucker your lips a bit. Okay, not your cheeks, but your lips, and you make the hole where your mouth is smaller by puckering your lips a bit, and it creates some back pressure into the lungs by letting the air out a bit slower. That's called pursed lip breathing. Okay, so I don't really like the answers here. It's basically you breathe in slowly through your nose. Okay, that's fine. So that's the only answer here, breathing in slowly through your nose. But the pursed lip part is really when you exhale, that you pucker your lips a bit. Okay, so because that's the only good answer here, because you don't puff out your cheeks, you take a deep breath. You take a deep breath in through your nose. That's the only correct answer. Okay, let's move on.